Welcome to the St. Emlyn's podcast. I'm Ian Beardsall, and this is a very special episode where I'm delighted to have Sheldon Cheskes on the podcast. Sheldon will be well known to many of you who followed his work through the DOSE-VF trial and others. He's just published a new paper in resuscitation, which I'm sure we'll talk about. And it was an absolute delight to meet him and his good lady wife in Zermatt at the Big Sick just recently. And he kindly agreed to come and chat to us at St. Emlyn's. Just in case there's anybody who listens to the podcast, Sheldon, who doesn't know who you are, would you mind just giving us a quick intro to who you are, what you do, and really what it is we're going to be talking about today?
For sure, Ian. I'm a resuscitation scientist. I've been doing this for about 30 years. I am a professor of emergency medicine at University of Toronto, and I oversee the EMS systems out here in the region of Peel and Halton, which are just outside Toronto, Ontario, Canada. I'm a scientist at St. Mike's Hospital at Unity Health in Toronto, and really enjoy resuscitation science. I got into this business because when I first started practicing emergency medicine, I really felt that far too many people were dying from cardiac arrest, and we really needed to do better. And that's been the hallmark of the work that I've done in this area. Certainly, most of my early work was focused on CPR quality when we really didn't know that CPR quality actually made a difference. That was some of my original work. And now, certainly, my focus is on defibrillation strategies, but also looking at work on using drones more effectively for emergency medical response, particularly in rural and remote communities.
So let's go back to a bit towards the beginning and where we are now. I've said on our podcast before that I think our shoot to the moon thing should be that in 10 years' time, nobody should die of ventricular fibrillation cardiac arrest. With the interventions we have, the science that you're doing and others are doing, this is a survivable condition that currently not many people survive from. And we are going to be focusing, I think, on those arrhythmogenic cardiac arrest today. We are not talking about the PEA, person got old, person got ill, person died. That is not the cardiac arrest we're focusing on. Can we just define a few terms before we start? Because we're going to be using them liberally. So do you mind just telling us a bit about what we mean by DSED, refractory VF versus recurrent VF, and maybe even just touch on what vector change is and why that's important?
So DSED is really the use of two defibrillators to deliver sequential shocks in a very short order to the patient. So really pads in the AL position, pads in the AP position, and sequentially shocking rather rapidly within less than 1 second between the two defibrillators. That's what sort of DSED is. Vector change is a change in pad position from what generally most people consider as the original pad position, which would be an AL position, to an AP pad position. So that would be called the vector change. And refractory versus recurrent VF, man, that has a million different definitions. I think when people think of shock refractory VF, most people think of that as people who require greater than 3 shocks to be resuscitated. And that actually involves probably 50% of patients who actually present in VF. When you look at a point of view of an electrophysiologist, they would tell you, though, that refractory VF is truly someone who you shock and they actually never come out of VF, even for a very short time. And these are actually relatively small proportion of patients in VF. And one of the studies we did, it was about 18% of our patients in the dose VF cohort. The much more common patient is a patient with recurrent VF who you shock them, they come out of VF for a short period of time, and then they go back into VF again. That's much more common. And really, I think one of the greatest misconceptions is that if a VF is recurrent, you don't have a defibrillation problem, that your problem is patient has an LAD lesion, there is a resuscitation problem, there's a drug problem. But our group really has been able to show that recurrent VF may also be secondary to inadequate defibrillation. And we strongly believe that DSED is effective in both those types of ventricular fibrillation, both refractory and recurrent.
So what we're really thinking about is that patient in ventricular fibrillation and the best things we can do to get them out of it to ensure at the very most basic level that myocardium is still getting oxygen. Because obviously when that heart's working so hard, no effective perfusion is going to die and then the patient dies. And over the last 20 years, you've been doing loads of work about how to make that most effective. And if we can pause and just think about dose VF, we have covered it before, but having you on the podcast is too good an opportunity to miss. Dose VF looked at dual sequential external defibrillation, vector change, and standard care and I think demonstrated pretty effectively that newer techniques or novel techniques were more effective. How would you convey the results of your trial to the listeners?
All the research previously in the concept of double sequential defibrillation was observational research. The trouble with observational research in DSED is most of those studies left DSED to a Hail Mary when everything else had failed. So when DSED was done, it was done at shock 6, 7, 8. By then, people are good and dead. When you defibrillate someone who's good and dead, they ain't waking up. So the focus of DSVF was really to do it as early as possible. And we felt by you combining that shock refractory definition with observational work that we did previously, because we were doing DSED before the trial, that early was better. And that's why we moved DSED up to after shock 3 in the algorithm. And we showed a doubling of neurointact survival using DSED compared to standard defibrillation. The study was not powered, as many people have incorrectly interpreted the study results, to compare DSED to vector change. That was not part of the study, and any interpretation of the results as being similar or DSED is not superior to vector change are ill-founded. They're not found in strong statistical knowledge of the study results itself. It was mainly two interventions compared against standard defibrillation. We found DSED to be superior, and as we've talked about previously in Zermatt, the question is, if DSED is that good, why don't we do it earlier? And that's the focus of some ongoing randomized controls in Europe, both in Sweden, in Norway, and in Denmark, looking at the concept of earlier DSED.
It does strike me as strange that we wait to do what is probably the most effective strategy. What is it about DSED and vector change that are meaning they are more successful in getting patients out of VF than our standard AL type pad position, what we call advanced life support?
For me, I just want to dissuade the thought that DSED and vector change are the same therapies. They're not. In the trial, DSED, the odds ratios, confidence intervals all favored DSED. The sensitivity analysis all favored DSED. The rate of rearrest was much higher with vector change than it was with DSED. And vector change seemed to improve survival, but not ROS. Whenever you see an intervention that doesn't improve ROS, but improves survival, you have to worry about confounding. And neurologically intact status was improved only with DSED, not vector change. So they're not the same therapy. What they do share together is an AP pad position. That's what they share together. And why is the AP pad position? The AP pad position is superior because it actually has a current path that actually provides more current in the AP pad position than the AL pad position. Current is what matters, it's not energy. And really, why it matters in refractory VF is the vast majority of refibrillation that occurs in the ventricle happens in the posterior inferior aspect of the ventricle. That's the part that actually is defibrillated more thoroughly by AP defibrillation and could be completely missed by AL defibrillation. We think that's the key mechanism of benefit of the AP pad position. With DSED, when you add AP to AL, you get a much more homogeneous distribution of current across the whole ventricle. And that's where we think the benefit of DSED is. People think, wow, DSED, maybe it's just we just give them so much heat and that's what does it. It's not that. It's actually distribution of current. And also, we're quite convinced when you have two shocks that are a half a second apart, the waveform in the myocardium after that first shock is not the same. And that's what the second shock is doing in DSED. It's more susceptible to that second shock. So those two concepts, change in waveform, distribution, I think is what benefits DSED. The AP pad position, I think that pad position is what makes that a superior for those particular patients.
Just quickly about the DSED. So the gap is important then. The first shock is preparing the myocardium, and the second shock is then shocking the myocardium in its prepared state. So this is not about having four electrodes all firing at the same time. It's very much a gap is important.
I think it is. And I think actually animal studies have suggested that if we actually narrow that gap even further, we may be even more efficacious. The trouble is a long held myth of defibrillator damage with DSED. And certainly some of our work has shown that if you do it simultaneously, so you press the buttons at the same time, there is a slightly increased risk of defibrillator damage. We found it at about 1 in 1,000. We have not to this day ever damaged a defibrillator using our sequential technique. So there's that sort of trade off. Probably simultaneous may be more effective, maybe slight more risk in my mind. In the future will be one defibrillator, four pads. You press one button, and a perfectly timed shock will occur. That'll be the future.
And we should probably mention at this point that this research is about using current devices differently. You are not selling a new device. You are not at the behest of companies who are trying to. So, all the work you're doing is purely on outcome. It's important, I think, to remind ourselves that this is not, you are not a shareholder, as far as I know, in any of the major defibrillation makers.
No, I am certainly not. And I will say, as a conflict of interest, that Zoll has funded much of my research, but this is not about Zoll defibrillators, Stryker defibrillators. We actually work with both of them in our study, and thank God we did. One of the beauty things of doing resuscitation science is collaborating with such wonderful scientists, because really the last paper we did, it could not have happened without them, because they were the ones who had the calculations performed for us to actually calculate the current of each individual shock, almost 1,900 shocks. Without them, we wouldn't have been able to do the work. So, no, I'm not here to really focus on a defibrillator manufacturer, more the physiology of why one may work better than the other.
And that latest paper that you're talking about is a retrospective look at the dose VF trial. And we'll let people read the paper when it comes out. But the headlines seem to me to be looking at whether or not it's the amount of current or the position of the current going through the heart. And do you think that there is a change that we're going to see with how we practice the defibrillation because of this? Or is it a signal that leads us mainly as a hypothesis generating type thing for more research in the future?
Yeah, so that's a great question, Ian. I think my feeling is there are a lot of people out there right now who already begin cardiac arrest defibrillation with AP, but the most of them focus on AL first, and that's because the ILCOR and ERC guidelines say AL first. AHA says AL or AP first. So there's certainly a diversion there in terms of what people think. I think anyone who says AL first does so because of speed, right? So time to defibrillation currently intuitively would think that AL could be done quicker. The trouble with that is speed does not equal efficacy. And if you're doing a defibrillation quickly, but it's not as effective as a different position, I think that will give people food for thought as should we change. Our paper itself certainly is observational, but it does certainly mesh with some work done by Josh Lupton and his work in Portland that also showed an observational study of a 2.6 times improvement in ROSC rates using an AP first as opposed to an AL first strategy. So our paper corroborates it, but it corroborates it with some incredibly interesting science. As we all know, that energy itself is not what determines defibrillatory success. It's really current. What is the current going through the ventricle? And what we're able to show in this study, in fact, is that regardless over a wide range of different currents, AP was vastly superior to AL in probability of ROSC. So this wasn't just based on a current of 15, 16, 17. When you talk about currents, we had between 15 and 25 amps, let us say. For all of them, AP was superior. So that suggests to you that it's not the mean value. Let's get more current. It may actually be what is the path of the current? And therefore, we found that the path of the current, i.e., in the AP plane, was superior than AL. I think current makes a difference, but the path actually is the most important. So I think people will look at it. And I think you made a great comment, Ian, in terms of hypothesis generating. I think to change practice really requires a randomized control trial. And that's actually our next step. At least this gives us some very good food for thought to look at a randomized trial. And that's what we're going to be doing here in Canada.
Your comment about speed over efficacy reminds me of the argument we've had about antibiotics and sepsis for the years. It doesn't matter what we give, we have to give it fast. And then
Yes.
we've realized that actually giving the right thing and taking some time to consider it is probably important. We're not talking about taking 20 minutes here to decide about pad position. We're talking about the difference between seconds, aren't we? But
Yes,
there is something
exactly.
also, which I'd be really interested to know what you think about how you change guidelines that seem embedded in people's psyche if you even remotely suggest doing anything slightly different to what is down as ALS, and I'm sure you and I can debate at length whether advanced is the right word to use in advanced life support, it does seem that even though there's a revision to the guidelines, they're not quick to take on new ideas. Do you have any inside information as to why that might be?
I've been on, as you can imagine, hundreds of podcasts since those VF has come out. And I've answered thousands of questions about issues related to the trial. And we've answered all those questions fairly convincingly. I think if I had a criticism of the trial, it's not a criticism, it's the only one. It's the only randomized trial. So, whenever you have one randomized trial, as a scientist, you have to maybe take a step back and say, let's look for confirmation. And I think that's a reasonable position for some people to take. ILCOR back in 2023 actually supported the use of DSED for refractory VF, and use of Lurge may be considered, and that was supportive and a marked change from their previous position in 2020. Where the guidelines went astray is the ERC suggesting a vector change as opposed to DSED because of lack of evidence for DSED and the systematic changes that would have to occur. Any evidence for vector change came from dose VF, so we found that a bit amusing. And I think anytime you tell paramedics they can't do something, they'll find a way to do it. For us in North America, anyway, I have very few EMS systems cannot get two defibrillators to a scene. I would argue that's much easier than putting an ECMO system of care into place for people with refractory VF. The AHA use the terms that hit the DSED has not yet been established. Both ERC and AHA, I feel, are much more opinion than science, unfortunately. ILCOR is a review of science. They supported DSED. I must tell you, it's extremely rare when a guideline body does not replicate the feelings of ILCOR. So I think that tells me there's lots of opinion. I think there are opinions of people who do the ERC and AHA guidelines who've long felt that DSED does not work. And those opinions apparently seem to carry the day in the guideline bodies. But I think we'll sit back. We continue to work hard doing great science on DSED, showing mechanisms of why DSED is better. And I suspect when you get a confirmatory study showing the benefit of DSED, you'll see ERC and AHA change the way ILCOR changed. So hopefully that gives you a sense of my thoughts on the guidelines.
And this is one of those times where acronyms are plenty, aren't they? And it just shows that even I'm inside this process a bit. And the difference between ILCOR, the International Liaison Committee on Resuscitation, the AHA, the American Heart Association, ERC, the European Resuscitation Council, and I think we even have the UK Resuscitation Council as well, all of whom are dealing with the same data and same evidence. And yet somehow the guidelines are different. And I think if you're being resuscitated from VF in North America, you may get different treatment to if you get it where I am in the UK. And that doesn't seem to make a huge amount of sense to me. But there's a lot of work going on with resuscitation of cardiac arrest. And we have this ALS, advanced life support. And I've long argued that it's not that advanced at all. In fact, it hasn't really changed since I was at medical school, and that was a while ago. If you were to look to the future, Sheldon, and say what true advanced life support looks like in the next 5, 10 years, what do you think that will look like for the everyday person who's practicing in emergency medicine and pre-hospital care? And perhaps what you would actually like to have now, if only we could get the guidelines to listen.
I can certainly say how we practice here in our systems. We start with pads in the AP position. I think that's warranted by the science, even pending a randomized trial. Sometimes you don't need a randomized trial. Sometimes you need common sense. And I think some of what we've done suggests starting in the AP position. I think when you look at drugs, I think in shockable arrest, I think certainly the work suggests we probably give too much epinephrine in shockable arrest. We're doing a trial out here known as Epidose, a randomized randomized trial looking at a maximum of 2 milligrams of epinephrine versus standard dosing. And I think this idea of minimizing epinephrine and shockable arrest will take hold. So we'll wait for the results of that study. I strongly believe that giving antiarrhythmics so late in resuscitation, so amiodarone, first dose shock 3, second dose shock 5, makes zero sense to me. I would be giving it after shock 1. Earlier antiarrhythmics makes much more sense. If we're doing standard defibrillation, I would use maximum energy. So on a Zoll defibrillator, it'd be 200 joules, 360 on a Stryker defibrillator. And likely, as we've seen in the Swedish feasibility study of DSED early, I suspect DSED will be done earlier, pending the results of future trials. So there's about 4 or 5 changes there that I suspect. I think people had become in love with IO medication, again, with a thought basis that IO could get you drugs quicker. Obviously, that did not pan out when looked at in a randomized controlled trial. And I think this is a big issue too between AL and AP. The thoughts that AL should be done first are purely based on speed, but speed is not the same as efficaciousness of defibrillation. And that's where I think AP comes in. I think from drug delivery, I think we're quite convinced that while IO was thought to be quicker, the delivery of antiarrhythmics as well as adrenaline is not as good in the IO route. And that's why I believe IV is preferred. So, yeah, there's about 6 or 7 things that I think are different. I suspect when you look at ALS, you look at guidelines, they're basically written for anyone who's doing resuscitation. I think this is a basic cookbook approach to resuscitation that won't get people into trouble. I think most resuscitation scientists out there that I speak to certainly vary a great deal from the guidelines based on their experiences in this particular field. There may be more than one way to actually resuscitate a patient, and I think that's what science shows us.
I mean, I'm guessing that the AL pad position came about because we used to use those handheld defibrillators, which I do remember, with some orange pads, and it was impossible to do AP. So I'm assuming that all we've done is taken an unproven way of doing it, then found a way to do it by not using those handled machines and using stickers, and then believing that's the best way. Is that genuinely the reason why we do AL and not AP?
Yeah, I think so. Listen, AL, you rip open the shirt, you apply the pads. It's quick, it's easy. And I'm actually, just to be safe, to be sure, I'm not saying for the non trained bystander responder that we change that. I would never want a bystander to put pads in AP. It's too difficult, it takes time. For them, I think AL was fine. But for a trained responder, we can take a couple more seconds, put the pads in the more efficacious position, and deliver a shock that's much more likely to produce ROSC than the AL position. I was once giving a dose VF talk to a group in Peru, and I go through this long 45-minute talk. Everyone loves it. The first question I give is, Dr. Cheskes, we don't have pads here. We have paddles. Can we do DSCD with paddles? So I said, oh my God, I just gave this 45-minute talk and you can't do DSCD. Then, about a month ago, I see a case report that shows a delivery of DSCD using paddles. It was the most incredible report I've ever read. This person had 10 shocks. They actually turned the patient in the left lateral decubitus position and with 2 sets of paddles shocked in the AL and AP position. And guess what? One DSCD shock, patient got ROSC and survived to hospital discharge, completely neurologically intact. So it shows you that even the concept with paddles actually works.
Now, we should move on and chat a little bit about the other work you're doing, just to finish off. We aren't saying to listeners, crack on and just do this in your resus room or on the back of your ambulance or by the roadside, are we? And we've always had this for 15 years on podcast. Just because you're here on a podcast doesn't mean you can go and do it. And actually, anytime I've tried to move anywhere away from guidelines in my own resus room, the amount of talk I have to do afterwards to debrief the team, to tell them that I'm not some rogue, often has been more exhausting than the resuscitation itself. So that is not the message we are giving, is it? But there are obviously things that we could do. We would say now you follow your local guidelines.
Exactly. So, you know what, Ian, most of the talks I give now are actually not to EMS. Most of my talks are given to emerge departments, ICUs, CCUs, critical care. That's where I give my talks. And what I say is always the same thing. If you're going to do DSED in your hospital, do it right. And what I mean by doing it right is one, expect refractory VF to occur. So after one shock, patients doesn't have ROSC, they're going to go into refractory VF. Be ready. Second thing, have a protocol in place. If you don't have a protocol in place, all that will happen is you'll look for the second defibrillator when it's far too late. And have a protocol in place that says, hey, after X number of shocks, we're going to move to DSED. Is DSED hard to do? It is not. What we did is after 3 shocks, 30 compressions, 2 ventilations, log roll the patient, place a posterior pad. 30 compressions, 2 ventilations, place the anterior pad. 1 full minute of CPR and 2 sequential shocks. And that's how we did DSED. And that's why you saw in the trial all the CPR quality in any arm of the study was guideline compliant because the paramedics had become so good at it and we developed a technique that works. So if you're going to do it, just don't do it ad hoc. Do it with a protocol in place so that you do it right and give the patient the best chance to live.
Just very briefly, Sheldon, you've mentioned other things that you also get involved with, so drone delivery and all sorts of exciting stuff that may help with resuscitation in the future. Give us a flavor of where you think this is going to go over the next 5 or 10 years.
I think one of the coolest things is the use of sensors to detect cardiac arrest in patients with unwitnessed cardiac arrest. We know these patients, 50% of them are not even picked up, they're not witnessed, and the patients have a much higher chance of death. If we developed an Apple Google Watch that picked up cardiac arrest, notified EMS, the chance of improving these patients' outcomes is much, much better. Jake Sunshine, University of Washington, Jake Hutton in Vancouver, fantastic work on the use of sensors. Our work here is looking at using drones to deliver AEDs in rural and remote communities, trying to build off some of the great work by Andreas Clausen in Sweden. And we think that's a great opportunity, particularly in these areas where response times are so poor. I think we can really make a difference. And we're taking it a step further. We're developing a medical kit in our drones that actually contain a naloxone, an EpiPen, stop the bleed kit to treat multiple time sensitive emergencies, not just cardiac arrest. Because if you use drone only for cardiac arrest, you're just not going to have enough cases. And many of these cases, opioid induced cardiac arrest is extremely common. Adding naloxone to our drone kit seems to make a lot of sense. So that's one big area that we're looking at. And the next area that I think really we need to really make a big difference in is post resuscitation care. So many people are discharged from cardiac arrest from a hospital. They have significant psychological challenges that are not being addressed the way we treat cardiac arrest. Most people, we discharge them, say, hey, take it easy, have a great day. These people need help. And I think rehabilitation centers for post cardiac arrest care are a must. And seeing that as standard, I think, is going to be the future. So, 3 different areas, I think: detection, accelerating response, post rehabilitation care. Those are, I think, 3 areas that I've got a lot of interest in moving forward.
Sheldon, it's been a joy to speak to you. And if you ever get the chance to listen to Sheldon do a talk, please do take it. He's a fabulous speaker and conveys this topic beautifully. Sheldon, thank you so much.
It's been an absolute pleasure.